from you. So therefore, please use to optimize your viewing screen, put your screen on the speaker view. And later on in the presentation, we're going to ask that you please use the reaction button at the bottom of your screen and use the raise hand icon. So at this time, I'd like to introduce you to tonight's speaker, Dr. Rachel Villanueva. She is a fellow of the American College of Obstetrics and Gynecologists. She's a clinical assistant professor of obstetrics and gynecology at the NYU Grossman School of Medicine. She earned a BS degree in biology at Yale University and her MD degree cum laude at the Yale School of Medicine. She is a board-certified obstetrics and gynecology and practices in New York City. Dr. Villanueva is a women's health expert and advocate for maternal health and reproductive justice. She is committed to health equity, the elimination of health disparities, workforce diversity, and clinician well-being. Having served as chair of the board and speaker of the House of Delegates, she recently completed her term as the 122nd president of the National Medical Association, the nation's oldest and largest professional organization representing African-American physicians and their patients. She is the first former president, of the Student National Medical Association to become president of the NMA. As a fellow of the American College of Obstetrics and Obstetricians and Gynecologists, she served on the Pregnancy and Health Disease Task Force, currently on the Health Equity Subcommittee of the District 2 Safe Motherhood Initiative, and was recently appointed as the Diversity, Equity, and Exclusive Excellence Advisor for the district. That's quite a bio. So with that said, I'd like to present to you Dr. Rachel Villanueva.
Thank you so much, Tanya, for that kind introduction. And thank you everyone for coming on this evening. I'm very excited about having to spend this hour with you. I want to first thank Black Health Matters and the Academy for Continued Healthcare Learning for providing this space for us to dialogue, to learn a little bit more about endometriosis, but even more importantly, to be able to talk about the disparities that exist in care for women of color in this country when it comes to endometriosis. I think we all know about the disparities that occurred during COVID and disparities we see when we talk about Black maternal health, but endometriosis is also in that category for us. And so I think having this time to come together and really learn from one another is a very important thing and special for us to do. So I want to thank them first for providing this time for us. So just a quick overview. I will give a little overview at endometriosis, certainly not exclusive, a very extensive one, but a nice overview for us, just for those who may not be as familiar with the topic. Then we'll hear from a patient advocate. And then finally, I think the best part of our evening will be that time where we have the opportunity to hear one another's stories, learn from one another, and really empower ourselves to take handle and hold of our own healthcare. So despite whatever may be happening in the healthcare system that may not necessarily be in our favor, that we'll still have good outcomes for ourselves and our community. So I'll start with the first slide, please. Okay, great. So this will be very kind of basic overview. So for those who may be a little more well-versed, it might be a little too basic for you, but I think it'll be a nice overview of what endometriosis is. And it's important to understand that it is a chronic and systemic disease. It's not really just a disease of reproductive organs, but it's actually a systemic disease of inflammation that occurs most often in women of reproductive age. So most often diagnosis is around age 30s to 40s, but can occur at any point during the reproductive life cycle. Endometriosis can present with many different types of symptoms. It's not just a one-shot deal when it comes to endometriosis. And I think that's what's one of the things that makes it most challenging for both patients and providers, is that it can be very varied. But really some of the hallmarks or the things that are most associated with endometriosis, I would say, would be that chronic pelvic pain, that can be cyclic, so associated with your menstrual cycle, but also in between menstrual cycles as well, and often becomes a chronic pain, and infertility. So I think those are probably two of the most common things that people associate with endometriosis, but it really runs the gamut of symptoms, or it may be completely asymptomatic as well, right? So there are some women who don't even know that they have endometriosis until perhaps they're trying to conceive. And we'll talk a little bit about that, more about that later. So it's a condition where tissue, the endometrial glands, are outside of the uterus. So the tissue that's similar to what's in our uterus or womb is outside of the uterus. And it doesn't necessarily mean that this tissue is in our reproductive organs. It could be anywhere. It could be on our bladder, our bowel. It could be attached to the inside of our pelvic wall. And these implants or nodules or lesions are that endometriosis tissue that's in those areas. Now that tissue is responsive to hormones, right? So that's another thing to keep in mind. It's responsive to hormones, and it causes inflammation when it's responsive to those hormones. So that inflammatory process causes the tissue surrounding it to become scarred potentially, and cause unnatural attachments, what we call adhesions, between different things in a woman's pelvis. Now that can be the reproductive organs, so it could be the tube, the ovaries, but it could be something like like I said before, the bowel or the bladder. So that's why the symptoms don't always present themselves as something as reproductive at all. How many people suffer from endometriosis? It affects women of reproductive age about 10%. Now, this breakout of who actually gets endometriosis is actually a little flawed, because endometriosis historically has been seen as a disease of white women or women of privilege. And that was really based on flawed research. It was based on biased research, and it was based on really thinking that wasn't based on what we now use, evidence-based medicine, right? It wasn't based on that. Many of the research studies that this was originally based on were conducted, and there was no diversity in actually the patient population. So 75% of the people that were actually studied were white. So as we come to know now, these kind of stratifications of who gets endometriosis is really artificial, which is similar to the way race is artificial. It's a social construct. I'll take the next slide. So making the diagnosis for endometriosis can be difficult, as we mentioned before, and is difficult because it can present in different ways. And oftentimes it doesn't even present as a reproductive problem. So for many women, they can spend many years, even decades, trying to kind of search for the root cause of the symptoms that they're having. They may go see many different doctors. They can spend a lot of time, money, energy, and it really kind of saps a lot of women and patients as they're really trying to kind of understand what's going on with their bodies, because we know when something is wrong, and women will know when something is wrong. Approximately 80% of women with chronic pelvic pain will have endometriosis, and about 50% of women with infertility will have endometriosis. So we see it's a very rampant problem, but most women aren't getting that diagnosis early on or very quickly. It's also a very expensive disease in time, energy, healthcare costs. 20 billion annually can be, we think, spent on this particular process. I'll take the next slide. So the title of our discussion today was using our voice in understanding disparities in care for women of color. And we know more recently it's become more to the forefront that individuals of color experience disparities in our healthcare system. Now, that's not necessarily a new thing. That's actually a very decades-old process. But over years and years and years, even through the identification of people of color experiencing poor outcomes and poor health just because of their race, the inequities still exist. And when I was in medical school, we would say, well, that person's risk factor was their race. And we really have come to understand that's not someone's race, because genetically we are the same. It's really racism, bias, those systemic policies and practice that have created an inequitable healthcare system. And so it's a very difficult, challenging problem to overcome. But it does very much affect how we as people of color experience the healthcare system. And for Black women, this is no different. We've seen more recently news and press about Black maternal health. We've seen the inequities that exist there. We understand that Black women are often marginalized, dismissed, not believed. And this also permeates into treatment and care in endometriosis. So Black and Hispanic women are less likely to receive an endometriosis diagnosis. They're less likely to be prescribed pain medication. But we know that endometriosis doesn't present differently in women of color. And so we know that it is these implicit biases and racism that does exist in our healthcare system that puts us at a disadvantage when we're trying to get care, and makes our care suboptimal in the system. There's research that shows that even medical students and residents have false beliefs about Black patients, that they may be more drug seeking, that they have more pain tolerance and require less pain medication, that even that our skin is even different. So there's a lot of bias within healthcare, within our educational system, how people are trained, and this translates into difficulties for us getting good care and for women to get that endometriosis diagnosis as well. Next slide. So making the diagnosis of endometriosis not necessarily quickly, but early on is really important in how someone's care, how well they'll do moving forward. So it is really important that you are well versed in knowing about the potential for endometriosis, what the symptoms are, that maybe you are at risk, and that the things that you're experiencing are not just normal menstrual cycles, but are really possibly endometriosis. So it is really important to have, first of all, a health home, having a doctor that you trust, not going to urgent cares, because you're not going to get the best care there. You need someone that understands your health history, your family history, and how this may impact your personal health. So a candid conversation with a healthcare provider is imperative. Early diagnosis is really important. It can lead to less pain and suffering, obviously, because it's addressed more quickly. Less severe anatomic distortions, because as we discussed before, those unnatural scarring or adhesions that can occur can impact your internal organs, your reproductive organs, can lead to things like infertility. So finding out early on is very important. Timely referral to a surgeon if that's needed, and overall just improving quality of life. Next slide. So I know I haven't painted the rosiest picture so far of endometriosis, if that's something that you have or think you may have. But the symptoms, but there is hope for us. And we'll talk a little bit about that later, but more importantly right now, I just wanted to focus on the symptoms that can occur with endometriosis and why it can be such a challenging diagnosis to make. So pelvic pain, cyclic pain, and infertility, those are things that are commonly associated with endometriosis. But we see that there's so many other really non-specific symptoms: nausea, sleep disturbances, headache, diarrhea, gastrointestinal symptoms. Some people think they might have irritable bowel syndrome. They might be eating something that they're allergic to. There are many symptoms or presentations of endometriosis that aren't classic and can often make it challenging for the patient and provider to try to discern what actually is happening. Next, but it is important to understand that it is very varied in its presentation. And so symptoms that may not be classically associated with endometriosis should really be considered. And that's why having a provider that you know well, that you trust, that takes a careful history, that is really centering you as the patient and tailoring the discussion to you is very important. Next slide. I think we talked a little bit about this just before, about why timely diagnosis and treatment is important for quality of life, potentially impacting fertility, healthcare costs, and worsening pain. Next slide, please. This just really shows a staging that healthcare providers will use to really chronicle what the endometriosis looks like on presentation. And this will be done through surgical inspection. And so the hallmark of diagnosis for endometriosis is surgery, which also makes it difficult because that's not really generally our first line for understanding whether a person has endometriosis or not. And the staging is based on where the endometriosis is, how extensive it is, whether that scarring is involved. And it really is more important if multiple surgeries are happening, or if you're going from one surgeon to another, that they can assess what's going on. But really the stage doesn't actually reflect your severity of pain. So a stage 4 doesn't necessarily have more pain than a stage 2. They could, but not necessarily. It also doesn't predict your infertility or challenges with fertility. Next slide. So there is hope. It's not all doom and gloom. I think when many patients come into my office and we're discussing maybe what the possibility that endometriosis their symptoms may be fitting into this particular process, the first thing a lot of patients will say to me is, I don't want surgery and I don't want medication. Well, great, because that's not necessarily the first line. So it's really important to understand that we have a lot of control over potentially how we deal with endometriosis. And so lifestyle modifications are very important, useful tools and management, and can be first line for patients. So that you don't have to be afraid that you're going to go somewhere and they're going to want to cut into you right away, and that's the only option you have. So physical exercise. And we know those endorphins that we get from good physical exercise can make us feel good, but they can also help us with endometriosis symptoms. Yoga, as a part of physical exercise, physiotherapy, diet. So a non-inflammatory diet. So those greens, salmon, berries, all those good omega-3s, chia seeds, flax seeds, all those things can potentially improve. Now, we're not saying each of these is a cure-all. Each of these may not work for you, but these are options that you can try firsthand, and you don't have to be worried about going to someone again and having maybe a treatment plan that you're not comfortable with initially. So these are things that you can, some lifestyle modifications that you can do. Cannabis has great medicinal properties, herbs, and Eastern medicine, acupuncture. So these are all really important tools that you can have in your own arsenal. Next slide. These are some of therapies, medication therapies that may be options that a provider might talk to you about. The oral contraceptives, the oral norethindrone, and the Depo-Provera, those are all hormonal balancing, because part of what happens with endometriosis is more of an estrogen increase and progesterone resistance. So sometimes those therapies can be can help improve your symptoms. They'll really sort of mitigate symptoms. These aren't going to cure your endometriosis, but they may make those symptoms manageable to the point where you don't need anything else. Non-steroidal anti-inflammatories such as Motrin and Advil can help, because there's an increase in a substance called prostaglandins in endometriosis pathology. Some of the older medications, GnRH agonists, really not important to get into specifically what they do, but overall they kind of put you into a mini menopause. So that decrease in hormones is helpful for the endometriosis, but it also affect lipid and your cholesterol. So they were good in the short term, but really overall they're not really helpful as long-term therapies. Some are newer therapies. These GnRH antagonists are really some very promising new therapies that have the benefits of kind of quieting down the estrogen without the terrible side effects of menopause, as I just said. And also one of the other sort of bad side effects of those other medications were affecting your bone metabolism and bone density. And so those newer medications don't have that. They've been shown, they were really medications to help with fibroid bleeding and heaviness, but they've been shown to help decrease with pain with intercourse, pain with period, and overall chronic pelvic pain. Next slide. And then finally, the last strategy, which is would be surgical management. Laparoscopy is minimally invasive surgical management, and laparotomy is an open, more invasive management that's not commonly used. Laparoscopy is really what's preferred, because it's decrease in overall postoperative pain, decreased need to be in the hospital, and decreased complications. We find that 80% of patients who have some type of surgical management, whether they're able to completely remove those endometrial lesions that are there or an endometrial cyst that might be there, have improvements of up to 80% of their symptoms after surgery. However, we see there's a very high rate of recurrence as well. So surgery was not always the best option, but minimally invasive is definitely the gold standard. Now we see that research shows that women of color aren't often given those minimally invasive options. Similar to fibroid surgeries, women of color, Black women, Hispanic, Native American, Pacific Islanders are often given the more invasive option and not the minimally invasive options. They tend to have more complications of surgery. They also tend to have their ovaries removed at an earlier age. Now, obviously, these type of things can affect someone's fertility. And we wonder, why are we not being given those options? And why are we subjected to more complications? Again, research has implicated bias in our healthcare system, access to resources that white women have, less skilled surgeons in the hospitals that are in our communities. All of these things factor into disparities in care that we experience. Next slide. All right, so that was a little longer overview. I'm sorry than expected, but hopefully we'll be able to discuss some other topics when we have our open discussion at the end. Now we're going to hear from Arminta, who's a patient advocate, and hear a little bit about her endometriosis journey.
Good afternoon. My name is Arminta. I am 41 years old, and currently right now with endometriosis, I am experiencing a lot of leg pain, lower back pain, and extreme fatigue. At the age of 16, while in high school, I began experiencing very painful cycles. Painful to the point that I was laying down in class, that I was having to call home to get picked up, and my mom initially just thought that this was just a painful period, and she'd give me some medicine and we just continue on. This went on for a little while, and she eventually took me to my gynecologist, who sent me to have a sonogram, and they discovered that I had an ovarian cyst. It was after they started monitoring that they realized that the cyst wasn't shrinking and that it was growing, and they decided to do a laparoscopy once I graduated from high school. The summer of 1999, when I graduated high school, I was 17, and that's when I had my very first laparoscopy done. It was then that they discovered that I had also endometriosis in addition to the ovarian cyst that I had. So the cyst was drained, and they got rid of as many lesions as they could of the endometriosis they found. And this is where my treatment journey began. So it was very, very hard. And of course, I was told at some point, once you get pregnant and have a child, the pain will go away, the endometriosis will go away, which again was, of course, false. Speed up time, by the time I'm 28 years old, I am now married and I'm trying to get pregnant. And of course, it was very hard for me to get pregnant. I think we actually had started trying at the age of 26. And I tried for a year knowing that it was going to be hard because I had endometriosis. And at that point was when I was prescribed a fertility drug, and that helped me successfully get pregnant with my son. Pregnancy was pretty normal. So very grateful to have a break from having my cycle, and I delivered my son, and I almost thought that, wow, maybe they were right, it was going away. But within a year, it was back, and it was back with a vengeance. And that's when I had my second laparoscopy done to help with the pain. And again, by now I'm prescribed much stronger drugs, but again, I'm really weary about taking stronger drugs because I can't function. Not only am I tired already, but a lot of those drugs would make me extra tired and feel like I can't function, but I have this child to take care of, I have a job to do. And it was hard. It was very hard. There were times, I have a 9-to-5, but I also run a photography business. There were times when I would be at a shoot, and this one particular time I can remember having to crawl up in the floor in a ball because I was in so much pain. And again, my diagnosis started and treatment started at the age of 17, so that's the beginning of my treatment journey. I was treated with birth control. I was treated with over-the-counter medications, and that's what I pretty much used to help control my symptoms throughout from the age of 17 to now 41. Since then, I have had a total of 3 laparoscopies done, and they all confirmed, of course, I have endometriosis, but I'm just thinking, you know, how helpful was it? My last one was the most different one than any of the ones I've had previously, and this is the second one after having my son. And with this one, I had this one because of pain I was having during intercourse, and not just pain, but I was bleeding like crazy during intercourse, and I was describing this, and this is part of my treatment journey. I was describing this to my doctor for probably a year and a half of this going on, and I think for a long time, and as amazing as she is, I love this doctor. She thought I was over-exaggerating, and it wasn't until about a year and a half of this going on that she went to, to examine me. And when she went to examine me and she put the speculum in, I started bleeding like crazy. And she was like, okay, this isn't right. And with this going on, I can only imagine how during intercourse, what's going on with you. So that's what led to my 3rd laparoscopy. And it was since then where she scraped my uterus really well. I actually haven't had a cycle for the last 5 years. And along with having that done in birth control, my doctors haven't been worried about it. We've talked about it every year. We are going to discuss different options this year now since it's going on year 5. But that's how my medical treatment has gone on from the age of 17 all the way up to age 41 where I'm at now. So overall, I've been very satisfied with my treatment. I'm just at the point now that I want to discuss what's next. I know that they are not concerned about the fact that I haven't had a cycle in so long because of the fact that I'm on birth control still, and that I had that last procedure. But for me, I kind of want to do another one just to explore, to make sure everything's okay, because it's been a long time since any sign of a cycle for me. And even though I haven't had a cycle, I still get all the pain that comes along with the cycles. I didn't mention that. And the issues that I'm dealing with now are just, I still have a lot of pain. My legs are hurting. I have a lot of lower back pain still. And so I am wanting to see what's next, to see, it's been 5 years since my cycle. I want to know what are my options now, since I'm not having a cycle, but I'm still having the pain that comes along with them. So what's next? I'm not sure what's next. That's where I'm at now, and that's what I want to discover. Good afternoon. My name is Arminta.
Of course, I'm not unmuted, but ills of the Zoom. So there's so much power in Arminta's stories and all of our stories. And so I really hope that at this point, we can have a really great discussion. There are many people on the call right now, and I hope that, or the Zoom right now, and I hope that if you feel comfortable enough to participate in the discussion, it's really where we learn from each other. I think it's really important for us to be able to share the good things and the bad things that have happened to us through our journey and in the healthcare system, because that way we can help each other. So if you feel comfortable enough coming off on screen, you can. If you don't have to. And then if you wouldn't mind using the raise hand function, if you'd like to share. And so I'm just curious, for me, her story resonates for me in that she's been dealing with endometriosis with chronic pain, with multiple surgeries since she was 17 years old, and she's 41 at this point. And the fact that she can still smile and be so warm is really a testament to the person that she is. But, you know, it is a really, you can tell it's a taxing thing as well, because she still is concerned about what's going on, despite the fact that she is doing relatively well in treatment. And what I also find interesting is that she says she's very satisfied with her treatment, but she's still in pain, right? She's still complaining of leg pain and back pain, but she's satisfied with the treatment that she's having. So I can only imagine what pain she was experiencing before, that she is now okay, smiling, but still in pain, but satisfied. And then finally, what I also found really interesting from her story was the fact that even though she trusted and really liked this provider that she was talking to, that she had to really tell the provider for 1.5 years that she was having this bleeding with intercourse that was really more than you know she should have had, that was really a lot, and that the provider was kind of minimizing that until that provider saw it for her own eyes. And so, you know, for us, that mistrust of a healthcare provider, because they're not listening to us, causes us not to get our care, causes us not to go into the doctor. We don't want to get care because we don't want to be minimized or belittled or dismissed. So a lot of times we won't go get care. And we know how important, especially with endometriosis, early care is. So I'm just curious if anyone out there can relate to what Arminta was talking about, if anyone's experienced any of those issues with a provider or issues with their treatment plan and is willing to share with the group. And I really can't see.
Well, Dr. Villanueva, I have one question that's come through in the chat, and it's they'd like to know what would happen if endometriosis is left untreated.
Well, that's a great question. I mean, I think the one thing about endometriosis is you can have it and not even know that you have it, right? So endometriosis can cause pain symptoms, as we were talking about before, all those symptoms that we were discussing. Probably one of the things that we worry about most is that scarring, that internal scarring that can cause that chronic pain that people experience. It can lead to gastrointestinal or even urinary symptoms. It can lead to infertility if it's scarring the fallopian tubes, which is the tube that brings the egg down into the uterus. So it really can have far-reaching and long-term ramifications if it is not treated. I definitely see a few hands up. I don't know if y'all want me to call on people or you will.
Okay.
I actually can't see everybody. I don't know. For some reason, I can't see everyone that's on so I can't see everybody's hands. I don't know if someone else can, like in the back.
If Latricia or Joanna would like to go ahead with their question.
Yes, my name's Trisha. Actually, my question is a two-part of what you just answered. Thank you for this presentation. I actually joined because I was diagnosed with ovarian cancer, but I always wondered because the same symptoms that Arminta spoke of, I had those symptoms when I was younger as well, and always wondered if maybe I was never diagnosed with endometriosis, and as the years went on, and I mean like 15 to 20 years, and then when the doctor, my gynecologist, decided that I would need a hysterectomy, that's when the cancer actually was found. So I always wondered, like, you know, as a doctor, have you ever had a case that possibly similar or maybe?
Well, I'd like to say I'm just happy that you're joining us, and sounds like you're well, and hopefully like your health is doing very well. I haven't specifically had a patient with this particular process, with this what you've described. But certainly it's and I think you actually touch on what makes endometriosis so challenging is that symptoms can be overlapping, and symptoms can be non-reproductive or appear non-reproductive in origin, but actually be endometriosis. I'm not aware of endometriosis and ovarian cancer necessarily being an overlap, but that, that could certainly be the case, but not likely, I think. But again, I think it does highlight that you had years and years of a chronic pain that really were not adequately addressed. And I think that is one of the most important things, if nothing else, that we take home, is that none of us should be dealing with any type of chronic pain for years without getting it addressed. If one doctor is not going to address it, go to somebody else. Sometimes you do have to trust your healthcare provider, but if that person is not addressing your issues, if your pain is not being treated to your satisfaction, it's okay to look to somebody else, and you should. And a lot of times you need to trust your gut. If your gut tells you that the person really isn't, you're saying one thing and they're saying another, and you're in parallel and not talking to each other, then you need to find another provider. So, because you should never go through 15 years of not having your symptoms adequately addressed.
Okay, I believe next in queue we have Joanna, and then after Gail Davis.
Hi, good afternoon. Thank you so much for putting this together. I saw the thing come across my Instagram, and I was like, I've never want to talk about endometriosis since my diagnosis. So I was really excited that this was being presented. So thank you for that. I don't necessarily have a question. I just wanted to comment. You were asking about, like, does anything resonate with the story that we heard? And so I was diagnosed with stage 4 endometriosis, and mine, I feel like I've had painful periods since I was like in college, but didn't really think too much of it. I was like given like really strong ibuprofen and was like, go about your business. And I just thought that was normal. But it wasn't until 2016 when I started bleeding from my belly button where I was like, something is wrong. And I was like, worst case scenario, I'm like, oh my God, I have cancer, but not knowing what was actually wrong with me. And so I went to like ER trying to figure out what's going on. They were like, oh, you have a cyst. So I went back to my GYN and I was like, hey, this is what's going on with me. And so she's like, oh, we can easily drain that, and like, let's send you for some MRI images. So I went for the MRI images, and I started talking to some friends and families about what was going on. And someone had flirted the idea to me about endometriosis, but I hadn't really heard about it. So I called my doctor and I was like, hey, this is what I think it could be. In addition to the cyst, do you know anything about this? And she's like, oh, it's not that. If you did have that, you would have XYZ pain. It wouldn't be in your stomach. You need to go see a gastrologist. So I saw about 5 different doctors before actually getting my diagnosis. I saw 3 different GYNs, the gastrologist, and then I saw a second ER person. Because I kept sharing my pain, I kept sharing my symptoms. Everybody just kind of kept giving me a different runaround. And it wasn't until I got referred to a specialist with my current provider, and she like took my medical history from like my very first cycle. And that's when I knew something was different with her, because she like took the time. And sometimes when you see doctors, they only see you for like 10, 15 minutes. I was in her office for an hour just talking about like my history, what I was feeling, what my symptoms were, reviewing images. And I was like, okay, this is the person for me. And so I definitely would encourage everyone else, like, making sure you're advocating for yourself, because I get it, doctors are busy, but this is our life and we have to fight for ourselves. So it really took a long time for me to get the proper diagnosis. And it didn't help because this is technically considered an elective surgery. So right when COVID hit, I was supposed to have my surgery and they had to postpone it. And I shared with my doctor how my symptoms were increasing, because at first they were only with my cycle, but then they started coming in between cycles. And I was like, I can't live like this. I was taking 8 Advils a day. And I was like, something's going to happen where like I might get another disease from these medications I'm taking. Because at that point I wasn't on birth control and that sort of thing. And so she ended up pushing my surgery up, and she advocated for me after I shared with her my concern, and she was able to get me scheduled, even though it was like the height of COVID. And she was able to fight, so I can at least have one person with me. So I definitely think having the right team made a big difference in my treatment. And so my surgery was in 2020. So I'm at a point now where like my pain is very minimal. But I do have some infertility stuff that I'm dealing with. So she referred me to another specialist, and I trust her judgment. So now I'm working with them to kind of figure out what I can do to protect myself, because she has, she told me what I have is kissing ovaries, where like they're all a lot of adhesions and like all these things. And so she wants to preserve my fertility because I'm pretty young, I'm 34. And she's like, you still have a chance because your uterus is healthy, but it's just like I have a diminished ovarian reserve. So that's kind of where I'm at now, where I'm trying to figure out like, how can I protect my fertility, given like I have all this information now.
Joanna, thank you so much for sharing your story, because I know it's not easy to kind of talk about such personal things in front of people that you don't know. But I think your story is just such a prime example of why we need to have discussions like this. I'm so, it just shows that if you keep pushing, right, and you went and sort of like thought you maybe had endometriosis, like your symptoms were like aligning with that, and you fought for yourself. And that's why it's important for us to come together, educate ourselves, ask questions, right? Ask what, I want the minimally invasive surgery, right? I want to preserve my fertility. I want to be able to have children in the future if that's what you want. It's so important that we come armed with our own information. And I'm just like, you just fired me up so much. I'm so impressed with your like determination for advocating for yourself, because that's really what we need to do, unfortunately. And that's the reality. It is unfortunate. Our healthcare system should not be like this. Black women shouldn't have to do this, but we do. And that's the reality. We really do have to do it. So thank you, Joanna, and good luck with your fertility journey.
We have like a minute or so left. If there are any more questions or any other stories our guests would like to share, now's your time.
Gail Davis, I have my hand raised.
Okay, Gail, please. I'm sorry.
That's okay. I have sympathy for those ladies because I'm 69. I had a hysterectomy at 37. And my first period was 16. And from the first one, I had 7-day, very heavy periods, and the pain never stopped. So when I finally had my daughter, the labor pains were the same pains I'd been having every month. So I told the doctor I could do this. But at the beginning of the journey, my mom would always take me to these male doctors, and they always said it was in my head. So when I could go to the doctor on my own, I made sure that I saw a woman doctor, because the last man doctor said it was all in my head. And I told him, when you have a period, let me know, then you'll know how I feel. So I walked into that female doctor's office, and she immediately diagnosed me with endometriosis. So, I went through a whole round of, I don't know if this new procedure is called DNC, where they would scrape your uterus. And then I had all these cysts and things growing on my ovary. So when they finally did the hysterectomy, I had asked that, can you just tell me when the fibroids get too big and you have to cut me, I don't want to be cut because I'm a keloider. If you can take it out vaginally. And she did. And that was the end of that. She left the ovaries there. And that's just to let you know what some of my experiences were, because even though I had those periods for 7 days straight, never deviated, always was on time. And the only thing that shortened them was when they sent me birth control when I was in college, because I didn't want to take that. But then I couldn't take it a long time because the birth control made me sick. They made me feel funny, so I didn't want to take them. So there are 4 girls in my family. I'm the oldest, and I have a younger sister. I wanted to, myself and my youngest sister, she had endometriosis too, but hers were lesions that connected her bowel and all this other stuff. So we both had to go through the fertility treatments to get the one child we could get. But I wanted to ask, was it hereditary? Is it hereditary? Do you know? And I thank you for your talk. inspiring.
Thank you so much for sharing your story. And before I answer a question, which I will, I just want to say, you know, again, it just shows how advocating for yourself, right? Asking for not the open surgery because you know you keloid, and she gave you a vaginal hysterectomy. Who knows if that might not have been what happened. It was also good that your doctor saved your ovaries, especially as a younger woman, because having your ovaries removed obviously puts you into menopause right away. But not only that, has been shown, especially if it's removed in younger people in their like early 40s or under 40, more risk of dementia, cardiovascular disease, or increased mortality of any type. So it is really important. Again, research has shown that women of color have their ovaries taken out earlier, twice as often, less than 40, than white women. So we need to know this going into doctors' offices when options are discussed with us, so we know how to keep ourselves healthy. As far as hereditary, yes, it has been shown to have familial association, and first-degree relatives have a 7 to 10-fold increase of having endometriosis. So if your mom did or your sister did, you're at much higher risk. So you do see it in families.
Okay, thank you for that.
I'm not seeing any. Okay, Ty, did you have a comment you wanted to make?
No, I actually have a question. Where do I find someone who specializes in endometriosis?
So there are, I think if we have a couple of slides, I think there's a slide with some resources that we can.
It's at the end of the here they are.
Presentation. You really want to look for a minimally invasive specialist, because these surgeries can be quite challenging. And there's an association of, I forget all the letters, but gynecologic laparoscopists. So people who specialize in minimally invasive surgery. That's not to say like all surgeons can't do minimally invasive surgery, but when it comes to really challenging endometriosis, where those adhesions or that scarring happens, it may even involve bringing in a general surgeon or other people, because it does involve other organ systems. The National Medical Association that I'm the past president of is Association of Black Physicians. We know that women of color or patients of color do better when they're seen by physicians of color, and that's an association of Black physicians. So with an OBGYN section and a subsection of people who are minimally invasive surgeons, so that's another option. And then the resources that are up there on your on the screen, which I'm sure will be also put up on the Black Health Matters website as well, I'm sure.
Thank you. That was great.
Okay. Are there any more questions or comments from our audience? I have one additional question in the chat. And that is, if you are to become pregnant, will that cure endometriosis?
It doesn't cure it. I think as Arminta mentioned, her symptoms got better because she didn't have her cycle, right? So it does what those medications who put you into menopause when you're pregnant, that's kind of what happens. It quiets everything down a little bit. So your symptoms will get better. Sometimes you'll go to a doctor that'll say, oh, getting pregnant will cure your endometriosis. It won't. But some women do feel better after they've had a child. Sometimes periods get better, more regular, less pain, but it's not going to cure the process. It's not going to remove the endometriosis, no. But it will get better during that time. And then maybe it's variable person to person. It might be better moving forward after that, but not necessarily. Like in Arminta's case, she was better for a while and then she went back to having really even more severe pain than she had before.
Okay. Well, if we don't have any other comments or questions, what I'd like to do is invite you to download a post survey that we have that we're going to post in the chat. We'll also make this video presentation available to you on YouTube that you can share with some of your friends and associates who weren't able to join us this evening. All right, so we thank you from Black Health Matters and the Academy of Continued Healthcare Learning and our partners at Indo Black and LJ Powerhouse. Thank you and good evening.
I did have one question.
Okay.
The Academy of Black Physicians, was that is that a website where we can look up and see about Black GYNs like in our area? I think Dr. Villanueva, you mentioned it.
Yeah, you can contact our national office. The information is www.nmanet.org, and you can be connected with our OBGYN section and they can help facilitate that.
You said the website was
nmanet.org. And it's the National Medical Association, and they can help put you in contact with our OBGYN section. Also, you can look at a website on social media, Health in Her Hue, Health in Her HUE, also is helpful in finding physicians of color as well. And my social media handle is Dr. Rachel Says, and I'm happy to help facilitate things in any way that I can as well. No medical advice, but I can help facilitate if you have any in finding somebody as well.
Thank you.
Okay, so if there are no other questions or comments this evening, we want to thank you again for joining us. And please share this video with anyone that you know that may want to know more about endometriosis and treatment. All right, good night. Thank you.
Good night. Thank you for sharing your stories.